So who would like to kick off? Right.
Good morning. Reference to the prostate presentation. Myself, I'm a survivor of 19 years. When I was given surgery in 1996, my consultant at that time was Mr. Thurston, and unfortunately, when he did the post-mortem on the gland, I was unfortunate to have two tumours, i.e. one internal, one external. A year later, unfortunately, I was given chemotherapy. How rare is it for a person to have it the third time? Another 5 years on, which is 2003, I was given combined radiotherapy and chemotherapy at the Western Park. Is this a rarity or does it happen quite regular?
Can you hear me? I don't know. I need a bit more story. Maybe I'll chat to you afterwards about that. I'm not quite sure what you mean by two tumours, one inside, one outside, and your treatment. So I'm more than happy to sit down with you and go through. But yeah, you get recurrent cancers, prostate cancer.
So basically, the gland was removed, and unfortunately, cancer itself will have come back in a later state from the second tumour. Correct?
Yeah, so if you have any surgery for any cancer, you can get recurrence, and the recurrence can be around where the surgery was, or it can be spread to lymph nodes or spread around the body. So we know that radiation helps in patients who've got local relapse. So yeah, we see it.
Okay. Thank you. Next one.
Thank you. My name's Shirley Harrison. I'm a patient. I'd just like to make a plea really to the clinicians, the professionals who are here, to have a better understanding of what is meant by side effects. We heard very clearly from Jean on the video that what it meant for her, what diarrhea as a side effect on what it meant for her was not going out. We heard from Helen that losing a driving licence meant you couldn't drive around the place and you're independent. That's worse now in cancer. When I was told that I might have peripheral neuropathy in my fingers and toes, I understood what the words were, but I didn't know it meant you will probably fall over more and you won't be able to play the piano. So I think really having an understanding of what it means for individuals, what these side effects actually mean for people, would be very helpful in having a bit more empathy with patients.
Yeah,
So how do we clarify that for patients then?
Well, I'd agree with that, and I think that I would like to think I'm relatively open to hearing patients telling me what's going on, but I haven't recognised the level of toxicity within my own patients, despite having a programme running at the same time, trying to manage the problems. So patients also need to tell me, and I think that I don't always think patients offload to their consultants enough. Maybe it's because we're closed and we don't look for problems, but it's both ways as well. I think that sometimes people come in to see the consultant, don't want to make them feel guilty about what we've done, but the only people I can learn from are patients. What have I done to you?
And I think, can you hear me? Yeah, I think too that clinicians have a responsibility to flag up possible side effects before the treatment rather than waiting for them to manifest themselves. I had head and neck radiotherapy. I'm a sailor. It wasn't till after I had the treatment that I was told I should never put my face in the sun again. Well, if you sail competitively, that's quite a big ask. So.
At the back first, Barry.
I suppose first step really in, can you hear me?
Yeah.
The first step really I think in understanding the issues that affect patients who are treated and cured of cancer is to understand how common these symptoms are, and we don't know for a lot of them. So John, I think we've been commended for actually asking these questions and looking, to see how common these effects are. I think they're very common, and I think patients are reluctant to discuss what their oncologists. I wouldn't think of guilt amongst patients, well, at least I'm cured, and they want to be thankful for that. the board, should patients be present at their MDT discussions regarding their care?
Not with the way MDT discussions are carried out at the moment, no. There would have to be a huge shift, and I couldn't see it ever working. I mean, I think patients have this belief that they're discussed at an MDT meeting and it's a very cosy discussion and they probably have 15, 20 minutes. But the reality is it's a minute and it's very, very task-focused and, driven. It was quite an eye-opener for me. I've been to a couple of MDT meetings now. But no, I don't necessarily think they should be there, but I think how the information that's discussed is communicated with them could be done better.
Well, we had an argument about this last night.
Yeah, we did.
So, I've got strong feelings about this. I think working in a situation, knowing how MDTs came about, I think it was predominantly, in a quality assurance process to make sure effectively there wasn't rogue people going off and doing stuff, not communicating with people, that really bad decisions weren't being made, and that's what's done brilliantly in the UK, probably better than any other country in the world. So I think that then trying to refine that and saying what are the individual, how does the patient-related individual features come down to the refinement of a decision. We were talking about it last night. I don't think you can do it in 5 minutes. I know that's what the doctor-patient conversation over half an hour is. What is important to you? These are the problems that are going to cause you. I don't think having that in MDT is possible. I don't think that's what the MDT should be there for. I think it's to make sure that every option that is appropriate is offered to the patient. That decision's made. Yes, you should offer these 4. No, you should offer those 2. That one's not appropriate. Have you done that bone scan? That's what I think it's for. Process at the moment.
Can I just check that everyone is familiar with the term MDT, multidisciplinary team? What we're referring to is the meetings where they make major decisions at the beginning and maybe further on about how a patient is going to be treated, investigations and treatment. Okay, next one.
I think there is scope, just an addition, and it was picked up on this morning, for there to be a supportive MDT meeting.
So yes, you next.
Thank you. The MDT, I think, is for the clinicians to make the decisions. But when the patient first meets with their specialist and is told the diagnosis, it would be handy if they also said what the treatment is likely to produce in terms of side effects, and then sent them to see a supportive care worker and to discuss the potential side effects and how to deal with them. Before that then informed decision can be made by the patient. My own experiences of Velcade being given to my husband with myeloma, and like Shirley, we were told peripheral neuropathy would probably be the side effect. But unlike Shirley, David's peripheral neuropathy went up and beyond his knees and up and beyond his elbows. And for someone to suddenly have to start wearing carpet slippers with Velcro on because it was the only thing he could bear to walk in, that was an amazing change. He also couldn't drive, but nobody explained that, and he was just so grateful to get what he thought was a treatment that was going to stave off the inevitable, without the discussion as to how it was going to affect his quality of life. Seemed unfortunate to me as a carer having to deal with it. So perhaps there's another step after the MDT, when you've all made a decision what you're doing, for the patient to be able to make their decision as to whether that is the right way forward for them on their treatment.
Yeah, and I would agree completely. And I think the MDT is a process.
Yeah.
There are 10 options, 4 of them appropriate for this patient's tumour, and then you've got a doctor-patient relationship about we recommend those 2 and you can choose between them, and this is the information you might need to help, and the amount of information we give always needs to get better.
It's very difficult for the patient who's being given what they perceive as a lifeline to challenge that lifeline in any way at all without knowing what the outcomes are going to be. It's a very
And it comes back to the point that Shirley made too, that it's all very well saying, well, if you have this treatment, you might have diarrhea or you might have a dry mouth, but it's going beyond that, because I didn't understand that having a dry mouth, which is what I now have, means I can't sleep because I have to drink through the night. So.
Thank you both speakers. Very interesting to hear from both perspectives, from the science and from the perspective of the person experiencing. I'm just concerned that if these proton beams cost £200 million, is there no way of looking at real-time imagery for actually doing the radiotherapy treatment? Would that not help with your moving bladders and bowels, etc., to actually target the treatment in real time?
Well, that is to some extent what the robotic gantry does. It does do it, but it's very, very slow and inefficient, so it takes 45 minutes to treat a patient. So, yes, you can do that, and if you've got a tumour that moves around like that, that's fine. But if you've got a tumour that goes like that, like a bladder or flips over, then you can't do real-time imaging without real-time adaptation, and that is much more complex. There are systems based on MR imaging, which isn't radiation, and therefore you can do it continuously. And so there are MR Linacs being developed, and there's 3 or 4 coming into the UK, but they are sort of experimental developmental machines, and you need to have the software to cope with it. The protons actually, at the moment, don't have sophisticated imaging on them as the Linacs that we use at the moment. So there are some challenges with protons. The cost should come down. So I think if protons become routinely used, and in a couple of countries in Europe, I think Sweden in particular, they're estimating that 10% of all their patients will be radiated with protons in time, then basically if you're going to be having 10 in a country, the cost will come down. But it's a cost issue, really. Thank you.
When I looked at the diagram of charities involved in supporting patients on the journey, one thing I noticed was, first of all, the absence of Hospice UK, but also really it made me think about what the evolving role of hospices are and other organisations in delivering supportive care. Richard and I had a very interesting brief discussion about actually about what palliative care is, and actually palliative care could have a relatively short half-life as a specialty unless we understand and develop a broader base, a much broader base to allow us to engage with supportive care. And I'm working with Sam, I certainly am one of the converted, that we need to develop a broader base. I think one of the things that's really interesting to me is in hospices are small organisations. Obviously, often you've got a small number of people doing their best to develop a range of services. And actually what we really need are trusts like Brains Trust and other bigger groups and Prostate Cancer Trust to develop interfaces to work with charities on a local level to actually be able to develop local services in the development of supportive care. The other thing that just is a thought is that in terms of MDTs, I don't know that disease-specific cancer MDTs are really ever going to be designed to address the holistic needs of patients. Whereas palliative care and supportive care MDTs might be. How can we enable patients in cancer-specific, disease treatment-focused MDTs to be picked up to do things like Spark, for example, and referred into palliative care MDTs, where we could look at the holistic needs of patients, and how can we engage smaller charities like hospices to grow the palliative care agenda or the supportive care agenda.
Right. Well, that might be best for you, Sam. I mean, I'll answer one on the MDTs and palliative care input. I think it would be optimal for every MDT in the UK for all tumour site-specific services to have palliative care input. We don't have it in our trust for urology, so that is a gap. But whether so that's would be the obvious route there, to have palliative care presence on the MDTs. But there are 10, 15, 20 site-specific MDTs running every week in every cancer centre in the UK. So that's a lot of manpower to sit there. So maybe it's a role of CNSs and the support workers to make direct referrals on. I don't quite know about that. In terms of the structure of palliative care in the future in the UK, that may be best answered by Sam.
Don't get me started on that. But I think the notion, though, about palliative care opening itself up to taking on patients at an earlier stage or survivorship, absolutely right on. I would guess that most palliative care MDTs, they're working up and down the country, are actually closed doors to the kind of things we're talking about today. They need to open those doors up. and that's part of the research agenda, because things don't happen just because we think it's a good idea. We have to show, and we're doing studies. There's a poster out there of you looking at early palliative care at the early stages of lung cancer, for instance.
And I think one of the other issues too is that the funders, particularly CRUK, only ever look at overall survival in the clinical trial arena. And until we can shift that and look at actually quality of life measures and have those moving further up the agenda, I still see trial protocols coming in without any reference to quality of life. And very often it's the very last bullet in the outcome measures. So there's a huge agenda to be driven there too. I'm working on it.
Alison Franks, oncologist and palliative medicine, so I sort of span both. I can partly answer the MDT issue. Part of that comes from peer review, which is advantageous, but it's also divisive in that palliative medicine is not core in all oncology sites. Now, why that is beyond me. I go to the lower GI one out of my own volition. The cancer team tried to stop me, saying, but you're not core, therefore you don't need to go. And I said, I don't care whether I need to go from a peer review point of view. I need to go from a patient point of view. So that's maybe an answer to part of that. I think one of the other things that's an issue to answer some of the patients' questions may be about clinicians are really stuck in cure. They often don't get beyond that. Now, some of that comes from the training and from medical school, where students are not told, they don't seem to get it through their heads, that 90% of the work they're going to do, unless they're surgeons doing hernias, is non-curative. It's about managing chronic disease. And until they get that message, we're going to have to keep banging and banging and banging on the door. So I think we need to go back to a real base level to get messages across and keep reminding people.
And that's not just for the clinical community, that's for the public as well. And it's about, a lot of it's about managing their expectations of their clinical team.
I agree.
They have too high expectations.
And then get so stuck in trying to get cured that they don't listen often to the bit of the information about the potential long-term side effects, and then forget that conversation never happened. So there's a lot of disconnects that are going on, but we can all make a difference to it.
Thanks. John, do you go to bed dreaming of cure, or can you look at other options?
Dreaming of cure. Dreaming of wine, I'd say. I think it's a very good question. I think there are challenges ahead of us. I think in England in particular, I believe that there's less follow-up being done in oncology communities. It's going more remote, going back out into general practice in a very rapid time. So if you think that oncologists like me don't know much about the side effects long term and be able to give informed, detailed information on how it's affect your quality of life, that's only going to get worse because we won't be seeing the patient, so we've got no way of tracking that. I think you've also got to remember that we've just had ASCO, where I think Matt Seaman's just probably come in from ASCO. We've had some fantastic press releases. We've got new treatments coming in tumour sites, lung cancer, prostate cancer, extending survival, immunotherapies that oncologists have got to learn how to do. It's very complex to work out how to introduce that into clinical service. So I think that oncologists will be concentrating more on survival. And so if we want to get supportive care, we've got to work out different ways of doing it. I mean, oncologists, that's what we're trained in, biology and new treatments, and supportive care is something that we're going to be doing less of. It's a gap to be filled, but I don't see there's going to be more oncologists giving dose-taxol chemotherapy for prostate cancer. It's going to have to be assumed with the current practice. So we will have to do less of other things, if I'm brutally honest. It's not the ideal situation.
Thank you. Right, next one. That's you. Sorry. No, you. Oh, sorry, Karen.
That's all right. Karen Holmes from Sheffield. Supportive and palliative care can go back to the 2004 to the document that arrived on everybody's desk, the workers supported. Quite a bit of a back to the new terminology of survivorship, living with and beyond cancer. I think we need to make sure that we connect across
Okay, thank you. Any comments on that, about the broader community, not just as we think about, say, hospices? What about other charities that might work in the community?
You're absolutely right about the GPs, because they're the primary carer once a patient is back at home. And I think probably nearly every day we'll get a patient or a carer to say, actually, you need to speak to your GP once they've identified what the issue is. But they do tend to be quite dismissive, you know, well, we will only see one brain tumour patient in our lives, so therefore we're not really geared up to deal with it. Yeah, and that's what we do, yeah.
See a lot of hands up. We've already got time for one more question.
Frank Jones, I'm a patient carer. I want to congratulate both of the speakers for even earlier this morning, because it's been fascinating and quite interesting. But specifically, I'd like to address something to Helen. You talked about brain cancer as a general term, but in fact, in my personal experience, my wife's cancer was a secondary to metastasis. There is clearly different outcomes for people who have primary brain tumours and people who have secondary brain tumours. But you didn't seem to address that point.
No, I only had 15 minutes.
Would you like to say a few more words, because I found what you said about lack of support once you get home, and just this lady here a moment ago saying about the GP influence. I mean, we couldn't get a GP to come out to my life. So if you could say a few words about your experiences of secondaries versus primaries, it would be very helpful.
Okay, so it becomes even more complex. You saw how complex the journey already is with a primary brain tumour, but with a brain met, it becomes even more complex, because you're having to involve multidisciplinary teams, you know, that are dealing with more than one cancer site. And there are treatments out there. There's the stereotactic radiosurgery. John's probably better off talking about this than me. But there are treatments out there, and I think it's absolutely crucial that patients with brain metastases do not feel written off, and they really drive and push to have further treatment, because their quality of life can improve and they can live for quite a long time with brain mets.
But the overall question is really, is it right that she should have been treated as a renal patient rather than a patient with a brain tumours? Yet the brain tumours are created under the problem.
It depends what you mean. As you talk about the oncological treatment, then yes, you base it on having renal cancer that has spread. But I guess if you're talking about the supportive care aspects, then there may be more parallels between a patient with a brain metastasis and someone who's got a primary brain tumour than there is between someone who's had a cured renal cancer. So it depends what you're asking. I think that what Helen mentioned is that as technical radiotherapy offers new treatments for very high dose, very accurately delivered radiation for brain metastases, the people doing that will be possibly the same people doing brain cancer work. So as it gets more specialised, so it may actually be there'll be a bit more joint support, because the teams will become specialised as brain radiotherapists, for example. If that makes sense.
I think you're right. That's where things need to move. Really.
Yeah.
I think it's probably going to be occurring naturally rather than by design.
Okay, thank you.
We may have one more question.
Hi, it's Richard Burr here from Christie Manchester. Thanks for both your presentations. I just want to say that I think if we're really going to truly embrace supportive care and some of these issues, we've got a bit of a problem in palliative care in terms of the way we kind of market ourselves. We're not very good at marketing and branding in palliative care. But I'm afraid words like palliative and hospice are associated with end of life. We want to really sort of change things radically. I think the other issue is that if you ask many palliative care services, they'll say that they're too overstretched to possibly deal with some of these supportive care issues. I just want to say that I think we've demonstrated, certainly where I am, that there's no growth in the comfort zone. And if you don't sort of put yourself out there and open yourself up and you team up to some of these other areas, then really we're never going to make any progress. It's really very, very important that palliative care changes the way it appears and embraces this whole continuum, including these earlier stages.
can I thank John and Ellen for their contributions this morning. There have been some fascinating points, as can be noted from the number of questions. As always, we've run out of time, but I'm sure many of the issues will arise again in the discussions, in the sessions after lunch.
Thank you, Malcolm. Yes, we can see still lots more hands bristling up. And for instance, I know that there are a lot of other people in the meeting today who come from other kinds of charitable services, including Maggie's and Trekstock and others, who've got services they can offer to patients in the community. The community is not just a sort of a sea. There are people, there are islands there as well of support, including in our own support service in Sheffield.